Present. Auzubillah minash shaitanir rajim. Bismillahirrahmanirrahim. Thank you very much, Professor Stephen Billing, and highly obliged. You have started different, very importantly, ends of the dermatopathology. And we are lucky here that you are with our students, our teachers, and especially in this group, there are dermatologists and histopathologists, both are sitting. And very encouraging that in Mayo Hospital, almost dermatopathology sections, biopsies are there. So today's we are starting the third session that is also very important. And over to you, Professor Stephen Billing.
All right. Thank you. Everybody I hope can see the screen. So, we're going to start off with sclerosing dermatoses. Primarily, we're going to talk about scleroderma and morphea, and then more advanced stages of lichen sclerosis. So in cartoon form, the sclerosing dermatoses are characterized by alterations of the collagen without much inflammation. So morphea, also known as localized scleroderma, presents as these indurated plaques, frequently on the trunk. They often have sort of a violaceous appearance to them. Microscopically, they're indistinguishable from scleroderma, and we'll talk about that in a little bit. Scleroderma is a multi-system connective tissue disease. There's two major clinical groups. The group 1 disease is more limited, involving the hands, forearms, and face, often have crest syndrome. The diffuse group, group 2, has more diffuse cutaneous sclerosis and even frequent visceral involvement. And clinically, patients have indurated skin. They can develop sclerodactyly, hypopigmentation with perifollicular pigment retention, and telangiectasias. Microscopically, both morphea and scleroderma are identical. You see thickened, hyalinized, and compacted collagen fibers. So you lose the normal spacing between the collagen fibers of the reticular dermis. And then you have usually a variable, mild perivascular lymphoplasmacytic infiltrate. And in the very early stages of scleroderma and morphea, before you see much alteration of the collagen, it's that perivascular lymphoplasmacytic infiltrate that is the clue to the diagnosis. So morphea and scleroderma are histologically indistinguishable. Other things that you might consider in the differential diagnosis: sclerodermoid graft versus host disease, which we've already talked about. Scar, normal skin from the back, if you're don't know what to look for, can be confused with scleroderma or morphea. So this is an example of morphea. Notice that we don't have the normal spaces between the reticular dermal collagen bundles. And you can see how it's starting to advance into the subcutis and impinge on the subcutaneous fat. And then there's a little bit of a mild perivascular lymphoplasmacytic infiltrate that we can see at higher power here. Notice the few plasma cells and lymphocytes. And notice you don't have any normal periadnexal adipocytes or fat. And notice that we don't have the normal spacing. There's no normal spacing between the collagen bundles of the reticular dermis. That is really very characteristic. Here's a different case of morphea or scleroderma. Again, you can see we're missing the normal spaces between the collagen bundles, and that it starts to extend into the subcutis a little bit as well, as we can see the sclerotic change in the superficial part of the subcutis. And that same sort of limited, usually relatively mild perivascular infiltrate that has lymphocytes and also some plasma cells. So in terms of practical tips to how to recognize scleroderma or morphea, it's been called the so-called square biopsy sign. It should probably be called the rectangle punch biopsy sign, because normally when you have a punch biopsy, the reticular dermal collagen bundles will sort of contract and it becomes more wedge-shaped. But because the collagen is sclerotic, you have a sort of a parallel arrangement of the punch biopsy. Normal back skin has fairly thickened, more robust collagen, so it often has a square or rectangular appearance, but you still have the normal spaces between the collagen bundles. Also, and when you see adnexal structures entrapped by sclerotic collagen, think about the diagnosis of morphea or scleroderma. Now, lichen sclerosus, we already talked about lichen sclerosus when we were talking about early stage lichen sclerosus, which is characterized by an interface dermatitis. Clinically, lichen sclerosus will present as white papules and plaques, often with some fine crinkling scale of the overlying epidermis. Has a predilection for anogenital skin, but you can also see it outside that area. You can see extragenital lichen sclerosus. And sometimes you can see cases of lichen sclerosus that have histologic overlap with morphea. Microscopically, once you get to the advanced stage of lichen sclerosus, you see an atrophic epidermis with the loss of the normal Reed peg pattern. Again, remember, if it's an early lesion, you might see interface change. But as it becomes more advanced, you'll see the classically homogenized or sclerotic papillary dermis. And then usually with a less intense lichenoid lymphocytic infiltrate underneath the area of sclerotic collagen. So just clinically, lichen sclerosus, again, tends to occur on genital skin. We get these white plaques. And this is what an advanced stage or the sclerotic phase of lichen sclerosus looks like. You can see this homogenized and sclerotic papillary dermis. And then beneath that is the remnants of the lichenoid infiltrate, because remember, lichen sclerosus starts out as an interface dermatitis. So the differential diagnosis can include things like morphea or lupus, because you can get some fibrosis in lupus, but usually it's not to the same degree. Remember that in the late stage of lichen sclerosus, that homogenization of the papillary dermis is the most important feature, and that sometimes you can get clinical and histologic overlap with morphea. And just as a reminder, early lesions of lichen sclerosus have interface change and can resemble lichen planus, but we've already talked about that in an earlier lecture. So I'm going to switch to paniculitis. So paniculitis is, the patterns are mostly divided into whether it is predominantly septal or predominantly lobular. It is important to remember that almost all cases of paniculitis have a little bit of septal inflammation and a little bit of lobular inflammation. So you want to look at where the most predominant inflammatory reaction is. And the ones we're going to talk about are erythema nodosum, erythema induratum or nodular vasculitis, lipodermatosclerosis, or also goes by the name of sclerosing paniculitis, lupus paniculitis, and I'm also going to talk about calciphylaxis, because that is in a way also a form of paniculitis, although it's sort of a combination of a thrombotic vasculopathy and paniculitis. So in cartoon form, for septal paniculitis, most of the inflammation is between the fat lobules, although you always see some inflammation at the periphery of the fat lobules as well. And in lobular paniculitis, most of the inflammation is within the fat lobule instead of in the septum. Erythema nodosum, at least in the United States, is the most common form of paniculitis. Patients develop acute onset of tender erythematous nodules, and most commonly involving the shins. It's often bilateral. We don't really understand why it happens. It's thought to be a hypersensitivity reaction that it may be idiopathic, may be associated with infections or drugs. Microscopically, you see a predominantly septal paniculitis. You'll see widened septae in the subcutis with edema, inflammation, and later on fibrosis. You can see lymphocytes, histiocytes, you can see neutrophils, you can also see some eosinophils. You will see small granulomas, again, concentrated in the septum. And then you will see some inflammation at the periphery of the fat lobules. Now, if you look at this case that I am showing you here, yes, there's inflammation in the center of the fat lobule, but it's clearly coming from the septum and going into the lobule, because most of the inflammation is in the septum and at the periphery of the fat lobule. Just a higher power picture of that same case. You can see again widening and fibrosis of the septum. You can see small little granulomas in the septum and this predominantly lymphohistiocytic infiltrate. But again, yes, it does have inflammation in the center of the lobule, but most of it is at the periphery. Just a higher power picture showing the sort of multinucleated giant cells, granuloma formation, and a mixed inflammatory infiltrate. predominantly composed of lymphocytes and histiocytes. Just higher power pictures showing some of these characteristic multinucleated giant cells and so-called Mischur's granulomas. So the differential diagnosis for erythema nodosum can include infection, trauma, erythema induratum or nodular vasculitis, lupus paniculitis, lipodermatosclerosis, and even subcutaneous morphia, because subcutaneous morphia can look a lot like erythema nodosum, except it's much less inflammatory. It's just sclerosis along the subcutaneous septa. Nodular vasculitis or erythema induratum is the classic lobular paniculitis. Clinically, you see chronic recurring tender nodules on the lower legs, and instead of the shins, it's usually the calves that are involved. It is, again, a hypersensitivity reaction. In some patients, it's a reaction to underlying infection with tuberculosis. That is less common in the United States. I'm not sure if that's more common in Pakistan or not. Microscopically, you will often see an acute vasculitis in the fat septa involving an artery or large vein, and then you see an adjacent lobular paniculitis with granuloma formation and fat necrosis. And in older lesions, the septa could be a little bit widened, but again, most of the inflammation is in the fat lobule. So here's an example of a case of erythema induratum or nodular vasculitis. You can see here's some vasculitis affecting this vessel. You can see the inflammation in the fat lobule, and notice the septum here is relatively spared. And just a higher power picture showing the vasculitis involving this arterial or large vein. The differential diagnosis is primarily with erythema nodosum, but remember erythema nodosum is predominantly a septal paniculitis, and it doesn't have an association with vasculitis. Infection, you can always consider. Polyarteritis nodosa, which you will also see a vasculitis involving small arteries, but you have less inflammation in the fat lobule. And we'll also talk about lupus paniculitis. Lupus paniculitis is sort of a mixed septal and lobular paniculitis, but doesn't have a leukocytoclastic vasculitis involving a vessel. Lipodermatosclerosis usually presents on bilateral indurated plaques on the medial aspects of the lower legs. It is essentially paniculitis caused by severe stasis change or venous insufficiency. So you tend to see that in patients who have bad venous insufficiency or in patients who are morbidly obese. All right, lupus paniculitis, I think I got a couple slides out of order. I apologize for that. Let's see. So lupus paniculitis, you tend to see in females more than males. It's associated with systemic lupus and discoid lupus or as an isolated finding. Lupus paniculitis presents as these erythematous or flesh-colored tender nodules, subcutaneous nodules, or plaques. And unlike the other forms of paniculitis I've talked about, lupus paniculitis tends to involve the upper body. So it tends to be on the arms, shoulders, face more commonly than the legs. In lupus paniculitis, you see lobular or mixed septal and lobular lymphocytic paniculitis. You see lymphoid aggregates, sometimes with germinal centers, and often with some plasma cells. And you tend to see this characteristic hyaline sclerosis of the fat. You may see a lymphocytic vasculitis, but you do not see a leukocytoclastic vasculitis. You may see some mucin deposition sometimes. And again, about 50% of cases are also associated with changes of lupus in the overlying epidermis. Here's a case of lupus paniculitis. You can see that we have some interface change up in the epidermis, so it has some features of lupus, discoid lupus here. But notice we have this sort of mixed septal and lobular paniculitis with these lymphoid aggregates, and you can start to see that hyaline sclerosis of the fat. Just to show you the coexisting features of lupus erythematosus. You can see this thickened basement membrane and evidence of interface change, as well as this perivascular infiltrate and some dermal mucin deposition. At higher power, as we go down to the fat lobules, you can see these prominent lymphoid aggregates. This one has some germinal center formation. And this is what we mean by the hyaline sclerosis involving the fat. That's a very characteristic finding of lupus paniculitis. Just a higher power picture showing that plasma cells are a frequent finding in lupus paniculitis. And plasma cells are not a common finding in subcutaneous paniculitis like T-cell lymphoma, which is one of the differential diagnoses. So I apologize, I got that out of order with my lipodermatosclerosis slide. So this, I'm going to go back to lipodermatosclerosis. In lipodermatosclerosis, you see widened septae, you see membranocystic fat necrosis. You'll often see these cystic cavities lined by sort of a crenulated hyaline membrane. And unlike other forms of paniculitis, lipodermatosclerosis is not that inflammatory. You don't tend to see much of an inflammatory infiltrate. At most, you see a mild perivascular lymphocytic infiltrate, but you will see features of stasis change in the overlying dermis with that lobular proliferation of thick-walled vessels in the papillary dermis. So this is what lipodermatosclerosis looks like. You can see, again, it's not very inflammatory. We see this sort of membranocystic fat necrosis where you can see these crenulated borders lining these sort of dead and dying adipocytes, these sort of cystic change within the subcutis. All right, just remember in paniculitis, you want to try to put it into a pattern, if you can, of septal or lobular, but some paniculitises have sort of a combination of both. Lobular or lupus paniculitis is well known to have be either septal or lobular, or usually it's a mixture of both. So just remember that, look for the predominant pattern. You know, what is the clinical presentation? If it's on the upper body, it's much less likely to be erythema nodosum or erythema induratum, and think lupus paniculitis. If you don't see much inflammation, you see that membranocystic fat necrosis, think about lipodermatosclerosis. If it's mostly in the septum, it's going to be erythema nodosum. If you see some vasculitis associated with it, think about erythema induratum or nodular vasculitis. We're next going to talk about calciphylaxis. Calciphylaxis is seen commonly in the setting of end-stage renal disease, and it happens in between 1 to 4% of hemodialysis patients. Now, we used to think that calciphylaxis was almost exclusively seen in the setting of end-stage renal disease, but at least when we reviewed all of our cases here at the Cleveland Clinic over a number of years, we found that about 40% of patients did not have end-stage renal disease. Other underlying disease associations included parathyroidism, malignancy, alcoholic liver disease, obesity, diabetes, warfarin treatment, protein CNS deficiency, etc. So sometimes it's not suspected clinically because the patients don't have end-stage renal disease. Calciphylaxis presents as painful, often ulcerated nodules and plaques, usually on the thighs, but you can see it anywhere. You tend to see it where you have more fat-rich areas like the thighs, the breasts, buttocks, but you can also see it in the penis, hands, etc. You can see it in any part of the skin. Importantly, to diagnose calciphylaxis, you need to have a generous sampling of the subcutis. If so, a shave biopsy or a punch biopsy may not be diagnostic, so you need to have a good, generous sampling of the subcutis. So microscopically, you see calcification of small to medium-sized vessels, most commonly in the subcutis. And if you're having trouble recognizing it on routine histologic examination, you can do a von Cossa stain to highlight the calcium. Other common features, vascular thrombosis, this sort of characteristic stippled fat necrosis. We have tiny little foci of calcium in the subcutis. You can see hemorrhage in the fat. Sometimes you'll see interstitial calcification or perieccrine calcification. And another common finding is reactive dermal angiomatosis. So this paper is sort of one of the best summaries of cutaneous calciphylaxis from Mai P. Huang out of the Harvard system. And just to sort of show what they found were statistically significant, again, stippled calcification in the fat, chunky calcification, calcification of capillaries to small to medium, or really any vessels, were all very characteristic of calciphylaxis. So here's an example of calciphylaxis. You can see this ulcer of the fat. Notice it's not all that inflamed elsewhere. Looks like there is some reactive dermal angiomatosis here. But then as you go deeper into the subcutaneous fat, you can see these calcium deposition around these medium-sized vessels. You can also see this stippled calcification here. These little fine dots are calcium deposition in capillaries, because between every adipocyte is actually a little capillary. We just don't normally see them because they're compressed by non-atrophic fat. And vascular thrombosis is a very common finding in calciphylaxis. That's what contributes to the ulceration of the overlying skin. Another thing you can see is perieccrine calcification. These are eccrine glands, and this is a von Casa stain, so you can see these stippled calcification around the eccrine glands. Now, it's not very sensitive or specific. Perieccrine calcification is not very sensitive or specific, but it is a relatively common finding. Now, another really nice paper from the Michigan group looked at calciphylaxis, and they also were one of the ones to really highlight the fact that dermal angiomatosis is a relatively common finding in calciphylaxis, this reactive vascular proliferation. And dermal angiomatosis happens in skin that suffers from localized ischemia. That's why you get this reactive vascular proliferation. And they also highlighted the fact that you can get widened septae, fibrotic septae, in cases of calciphylaxis, so you might confuse it with late-stage erythema nodosum. But erythema nodosum is not associated with calcification of vessels or not associated typically with ulceration of the skin. So the differential diagnosis for calciphylaxis can include traumatic fat necrosis, but traumatic fat necrosis is usually solitary, whereas calciphylaxis is usually not. And there's no ulceration, and you don't see vascular calcification. Pancreatic fat necrosis, I don't have time to show you pictures of that, but that shows widespread calcification of the fat, and patients usually have documented pancreatitis. Erythema nodosum is not ulcerated, so remember that, although you can, and it doesn't have vascular calcification. And pyoderma gangrenosum presents as ulcers, but you don't see calcification of vessels in pyoderma gangrenosum. Next, we're going to talk about immunobolus disease. And I don't have time to talk about all the different types of immunobolus disease. I'm mostly just going to talk about pemphigus, bullous pemphigoid, and dermatitis herpetiformis. So, immunobolus disease, you can have it as a subepidermal blister, in which the entire epidermis is lifted off the underlying dermis. Or you can have an intraepidermal blister or acantholytic type blister, in which you see the desmosomal attachments of the keratinocytes fall apart, but the basal layer of the epidermis is still attached to the underlying dermis. So in bullous pemphigoid, you see this has some clinical overlap with pemphigus and sometimes can have some clinical overlap with contact dermatitis, because contact dermatitis can develop blisters. Generally affects elderly patients. Usually you see bulla on the extremities or intertriginous areas, abdomen, and you can see oral mucosal involvement in about 1/3 of patients. It is an autoimmune disease in which you get an autoantibody, that's an IgG antibody that's directed against hemidesmosome proteins. And remember, the hemidesmosomes help bind the epidermis to the basement membrane, so if you destroy those, that explains why it's a subepidermal blister. This is a classic clinical presentation of bullous pemphigoid. You see these tense blisters on a background of an erythematous background, and notice the erythematous background here can somewhat look like urticaria. We call that like an urticarial lesion or pre-bullous or urticarial phase of bullous pemphigoid before it develops into these tense blisters. Microscopically, you classically see a subepidermal blister with a mixed cell infiltrate that contains frequent eosinophils. And then under direct immunofluorescence, you will see linear deposition of IgG and complement C3. In the early phase of bullous pemphigoid, before you get blisters, you can see eosinophilic spongiosis, and you can see eosinophils sort of tagging the basal layer of the epidermis. Differential diagnosis can include epidermolysis bullosa acquisita, which tends to be less inflammatory, or IgA bullous dermatosis, which can be histologically indistinguishable, though that tends to be more neutrophils rather than eosinophils. And again, dermatitis herpetiformis tends to be more neutrophils. So this is a classic case of bullous pemphigoid. You can see the subepidermal blister. There's no remnant basal layer here. Blister cavity filled with eosinophils. And then on direct immunofluorescence, you see linear deposition of both IgG and complement C3. Next, we're going to talk about dermatitis herpetiformis, which tends to occur in a younger population, men more frequently than women. You get pruritic burning vesicles, especially on the extensor surfaces, so the elbows are one of the most common locations. Clinically can resemble herpes, that's why it's called herpetiformis, or might even resemble a contact dermatitis. It is associated with underlying celiac disease, and in patients with celiac disease who have dermatitis herpetiformis, you can get them to respond to a gluten-free diet. And under direct immunofluorescence, you will see IgA deposits along the basement membrane. But instead of a nice linear pattern like you see in bullous pemphigoid, it tends to be concentrated in the dermal papillae because the antibodies attacking the basement membrane anchoring fibrils, and those are more prominent in the dermal papillae. So here's a clinical example of dermatitis herpetiformis. Because it's so pruritic, it's rare to see an intact blister because most patients will have scratched them off. Microscopically, you'll see a subepidermal blister. You'll see neutrophilic microabscesses in the dermal papillae and a neutrophil-rich infiltrate. The differential diagnosis can include cicatricial pemphigoid and linear IgA bullous dermatosis. Linear IgA bullous dermatosis and dermatitis herpetiformis very closely resemble each other microscopically, and you might need direct immunofluorescence to sort them out. So here's a classic case of dermatitis herpetiformis with an intact blister. But again, remember I told you intact blisters are relatively uncommon in dermatitis herpetiformis. What you usually will see is you see some neutrophil collections up in the dermal papillae in the non-blistered skin. This little micro abscess in the dermal papillae is a good clue to the diagnosis of dermatitis herpetiformis. And under direct immunofluorescence, you will see granular deposition of IgA along the basement membrane zone with most of the intense immunoreactivity at the top of the dermal papillae. Pemphigus vulgaris presents in the 4th to 6th decades with an equal sex distribution. It is another autoimmune blistering disease. Oral involvement is really quite common. It's not uncommon for patients to present with their initial manifestation of their disease with oral involvement. And in pemphigus vulgaris, you'll get an antibody IgG against desmoglein 3, which is part of the desmosome proteins. And so desmosomes hold keratinocytes together, so when those are destroyed, they sort of fall apart and became acantholytic. So in pemphigus vulgaris, you see flaccid blisters instead of tense blisters. So the blisters are easily ruptured. So they can occur all over the body, but remember, oral involvement is really quite common in pemphigus. Microscopically, you see acantholysis with intraepidermal blister formation, and the basal layer is spared. In other words, the basal layer is still attached to the basement membrane zone, which has been described as creating this sort of tombstone-like layer with the basal keratinocytes sticking up into the blister cavity. You'll often see eosinophilic spongiosis or eosinophils within the epidermis, and then in the dermis you see a mixed infiltrate with frequent eosinophils. Direct immunofluorescence, you will see both IgG and complement C3 around the keratinocytes. Differential diagnosis can include Grover disease and Haley-Haley disease, but neither one of those will have positive direct immunofluorescence. So here's a case of pemphigus. This is a lesion from the face. You can see all the hair follicles. You can see all this prominent acantholysis where the keratinocytes are falling apart. Notice the basal layer is still attached to the dermis. Just a higher power picture showing you the acantholysis and how it's sparing the basal layer. This is a biopsy from on the left from oral mucosa. You can see the squamous mucosa. Notice it's sparing the basal layer. So this is an intraepidermal blister involving the oral mucosa. And here's a biopsy from the skin. You can see this prominent acantholysis, but again, sparing of the basal layer. And on direct immunofluorescence, you will see circumferential or intercellular deposition of immunoglobulin IgG and complement C3. Now, another blistering disorder is Grover disease, a transient, or also goes by the name of transient acantholytic dermatosis. Tends to occur more commonly in men than women, at least in the United States. It's more common in winter. Patients will develop these pruritic papules and vesicles, usually it's small little papules on the trunk. Etiology is unknown. It has been associated with sun exposure, increased sweating, or even radiation exposure. The acantholysis resembles pemphigus. You can see this acantholysis, but it also has these corons and core grains, which resemble Derrier disease. It can also have spongiosis, and remember, it does not have a positive direct immunofluorescence finding. So here we can see this acantholysis, and here we can see these corons, these sort of round abnormal keratinocytes, and these core grains, up here with these sort of prominent, sort of flattened nucleus that look like a rice grain, where it's acantholytic. All right, so practical tips for immunobolus disease. It's not always possible to give a specific diagnosis, especially if you don't have information about the direct immunofluorescence findings. So in that case, you can give a descriptive diagnosis of like a subepidermal blistering disease and suggest a differential diagnosis. If you are taking a biopsy for direct immunofluorescence, remember to do a perilesional biopsy, not a lesional biopsy, to help confirm the diagnosis. And now we're going to sort of finish up the last 20 minutes or so, or maybe a little bit less, because I have a meeting I have to get to. Other inflammatory conditions. So this is a very common clinical scenario for me in my practice, is the patient will be hospitalized, they get a biopsy of an ulcer, and the clinician is worried about the diagnosis of pyoderma gangrenosum. And I used to find this to be very frustrating. It's not actually that frustrating because we can only do so much as a pathologist to make that diagnosis. So let's talk about pyoderma gangrenosum in a little more detail. Typically presents in middle-aged patients. It's somewhat more common in women than men. Patients will develop large, painful ulcers. The leg is the most common site. You can see it in almost anywhere. They have this situation called pathergy. In other words, the ulcers will develop at sites of trauma, or if they have an incision involving an ulcer, it gets worse. We're not exactly certain about the etiology. We are learning a lot about the etiology. It appears to be an unusual autoinflammatory condition. It is associated with other autoimmune diseases or like inflammatory bowel disease and arthritis. It can also be triggered by medications. Microscopically, the features are nonspecific. You see an ulcer, often with sort of a rolled, undermined border, and then in the ulcer bed, you see a dense neutrophilic infiltrate. Now, important to recognize that to make a diagnosis of pyoderma gangrenosum, yes, you need to have a biopsy-confirmed ulcer, but most of the diagnostic features rely on the clinical features, not the histopathologic features. So summarizing this very nice paper that I refer to quite often in my practice, the Mavrakis et al. Paper from Delphi consensus for the diagnostic criteria for ulcerative pyoderma gangrenosum. Well, you get a biopsy and you see an ulcer with a dense neutrophilic infiltrate and you exclude infection with special stains. So that is the single major criterion for making the diagnosis of pyoderma gangrenosum, an ulcer with neutrophils without evidence of infection. So to make the diagnosis of pyoderma gangrenosum, you need the major criterion, but you need 4 minor criteria. And the minor criteria are all clinical features: pathergy, history of inflammatory bowel disease, history of a lesion that rapidly ulcerated, peripheral erythema with undermining, multiple ulcerations with at least one on the leg, cribriform scars, decrease in size after 1 month of immunosuppressive medication. So you have 4 of those features, and the single major criterion, the only histologic criterion, is an ulcer without evidence of infection. So the differential diagnosis, of course, includes infection, so you'll need to do special stains. A venous stasis ulcer, but remember, venous stasis ulcer occurs in the setting of venous insufficiency, and you tend to have that lobular proliferation of thick-walled vessels in the papillary dermis, and venous stasis ulcers are usually not that inflammatory. And sweet syndrome, but sweet syndrome, you get the dense neutrophilic infiltrate, but you don't have an ulceration. Here's an example of a stasis ulcer. Yes, it's ulcerated, but notice in the adjacent uninvolved dermis, you have that relatively thick-walled collection of blood vessels in the papillary dermis. Sweet syndrome, again, you have a dense neutrophilic infiltrate, but you almost never really get ulceration in sweet syndrome. So, practical tips for diagnosing pyoderma gangrenosum. Well, one, you as a pathologist cannot diagnose it. Really, the only thing that you can make as a diagnosis as a pathologist is an ulcer with a dense neutrophilic infiltrate and with a comment. And usually this is the type of comment I will put in my report, that sections demonstrate an ulcer and associated with a dense neutrophilic infiltrate. This could be compatible with pyoderma gangrenosum in the appropriate clinical context. However, establishing the diagnosis of pyoderma gangrenosum is largely based on the clinical presentation, and clinical pathologic correlation is essential, and then I usually cite that paper I showed you at the beginning of this section. Another sort of unusual inflammatory disease can be ulcerated is chondrodermatitis nodularis helicis, or also goes by CNCH. Tend to see this in middle-aged to older patients. You'll see a crusted or ulcerated lesion on the helix or the antihelix of the ear. It's often on the patient's predominant sleeping side, so if you sleep on your side, you may be at risk for getting this. And it's essentially sort of like a small pressure ulcer. Clinically, though, it mimics squamous cell carcinoma or basal cell carcinoma, so it often clinically comes in with the diagnosis of rule out squamous cell carcinoma. Microscopically, you see an ulcer, and you will see some adjacent reactive epidermal hyperplasia. And in the base of the ulcer, it's not very inflammatory, but you see this sort of fibrin deposition and this fibrinoid degeneration of the dermis. And beneath that, you may see a proliferation of perichondrial fibroblasts, but that's really not the most important feature. The most important feature is this fibrinoid degeneration of the dermis. So in terms of practical tips, have a high index of suspicion from any biopsy from the ear and look for that fibrinoid change, and the adjacent epidermis does not show any true atypia. So here's a classic example of chondrodermatitis nodularis helicis. You can see this ulcer here, and notice all this prominent fibrin deposition in the bed of the ulcer. And then you also have this reactive vascular proliferation around it. Higher power picture just showing you that dense sort of fibrin deposition in the base of the ulcer, and notice it's not very inflammatory. And this is the reactive vascular proliferation often you see with it, these perichondrial fibroblast proliferation, this is the underlying cartilage, but those are less important features. The most important feature is this fibrin in that ulcer bed and the clinical presentation on the helix or antihelix of the ear. I'm going to sort of finish up with nutritional deficiency dermatoses, because these are sort of uncommon but clinically important because they're easy to solve if you can just get the patient the proper nutrition. Pellagra is a deficiency of niacin or vitamin B3 or tryptophan. associated with high corn consumption and alcoholism, also associated with anorexia or malabsorption in patients with severe inflammatory bowel disease. Can also be seen in carcinoid syndrome. Classically, it's the 3Ds clinically, clinical triad of dermatitis, dementia, and diarrhea. The dermatitis is a photosensitive erythema-like reaction that progresses to a dry scale with brownish discoloration, sharply demarcated, symmetric on the dorsal hands, forearms, knees, chest, neck, and face. The so-called Casal's necklace, where you get this thickened skin and sun-exposed area of the neck. And then gastrointestinal symptoms include diarrhea, nausea, vomiting, and patients also get neurologic symptoms, including headache, depression, ataxia, dementia, and delirium. This is a clinical case that we had here. You can see this sort of thickened, scaly skin and sort of the neckline or Casal's necklace distribution. Microscopically, it's quite variable. You can see hyperkeratosis, acanthosis. You can see increased basilar hyperpigmentation and variable psoriasiform hyperplasia. You can also have parakeratosis with pallor and vacuolization of the upper epidermis, similar to other nutritional deficiencies. Here you can see parakeratosis and hyperkeratosis. You can see the sort of vacuolar degeneration of the upper part of the epidermis. Notice the psoriasiform hyperplasia that we see here. Just a higher power picture showing the parakeratosis, that vacuolar degeneration of the upper part of the epidermis. And in this case, you don't really have that. You have the hyperplasia and prominent hyperkeratosis, and there's a bit of increased melanin deposition along the basal layer of the epidermis. Just a higher power picture showing the parakeratosis and hyperkeratosis. Acrodermatitis enteropathica. This is an autosomal recessive disorder of zinc malabsorption. Patients develop diarrhea, stomatitis, and failure to thrive. You tend to see a crusted rash with vesicles and pustules and erosions on the extremities, and also perioral, like we see here, and perineal skin, like we see in this picture. You can see an acquired form of acrodermatitis enteropathica secondary to zinc deficiency in diseases such as Crohn's disease, alcoholic cirrhosis or pancreatitis, chemotherapy, hematologic malignancies, total intravenous hyperalimentation if they haven't supplemented it with zinc appropriately, dialysis, etc. Microscopically, it's variable. Early on, you will see parakeratosis alternating with orthokeratosis. In more established cases, you'll see prominent parakeratosis, a decreased or absent granular layer, and then the very characteristic marked pallor of the keratinocytes. Late stages, you'll see marked cytoplasmic vacuolization and even necrosis of the epidermis with intraepidermal vesicle formation. So here we can see this prominent parakeratosis. Notice the absence of the granular layer. Notice the sort of ballooning or vacuolar degeneration of the keratinocytes up in the upper part of the epidermis. Just a higher power picture of the same, showing the parakeratosis, that vacuolar or ballooning degeneration of the keratinocytes in the upper part of the epidermis. Just one more higher power picture of that. And this is a more advanced stage where you can see essentially complete necrosis of the epidermis. But you can still get a sense of that pallor or that vacuolar degeneration of the keratinocytes in the upper part of the epidermis. Just a higher power picture showing that. Now, an entity with essentially the same histologic features is necrolytic erythema migrans. This is often associated with an underlying islet cell tumor, a glucagonoma. Patients have hyperglucagonemia. They will also have diabetes, glossitis, anemia, etc. You can get a pseudoglucagonoma syndrome in which patients have a disordered glucagon metabolism or malabsorption secondary to inflammatory bowel disease. Clinically, it somewhat can have a resemblance to toxic epidermal necrolysis, but it tends to be waxing and waning. Often involves the central face, perineum, intertriginous zones, buttocks, and extremities. You get erythema that progresses to blisters. Sometimes it's annular or serpiginous. Here we have some examples. You can see the sort of perioral disease here on the extremities and around the buttock, and you can see that here is more annular appearing. Practical tips, it looks exactly like The histologic features of necrolytic erythema migrans look exactly like what you see in zinc deficiency. So you see parakeratosis, ballooning degeneration of the keratinocytes, etc. If you're uncertain, if you don't have a good clinical history, you can call it a psoriasis dermatitis and then notice the marked pallor and ballooning of the keratinocytes, and that these features can be seen in the association in the setting of nutritional deficiency disorders such as pellagra, zinc deficiency, or underlying glucagonoma or necrolytic erythema migrans. And that clinical correlation is essential if you don't have good clinical history. I'm going to talk about one last thing, not because it's all that common, but again, because it does happen occasionally. And it has very characteristic findings if you know what to look for, and that's scurvy, which we all know this is a vitamin C deficiency. And cutaneous signs, you see dry skin, follicular hyperkeratosis, perifollicular hemorrhage, see all this perifollicular hemorrhage, and classically corkscrew hairs. You may also see alopecia, swollen gums, and tooth loss. Just a higher power picture here showing these corkscrew hairs with associated perifollicular erythema. Now, microscopically, there is a clue. This is a biopsy through one of those corkscrew hairs. You can see here, the hair looks like it's coming into the epidermis here, and the follicle should be down here, but the actual underlying follicle is here because it's corkscrewing its way up into the epidermis. And then notice there's some perifollicular hemorrhage. This is very common. This is the histologic correlate to what we see clinically, is that perifollicular hemorrhage. And here's another follicle with prominent hemorrhage around it, and that's a clue to the diagnosis of scurvy. Again, not very common, but it is so characteristic that if you see it, you can save a patient's life pretty easily. So remember, follicular plugging, corkscrew hairs, perifollicular hemorrhage. To demonstrate the perifollicular hemorrhage, it might require multiple deeper levels in the on your tissue block. And with that, I'll end and I'll take a couple questions before I have to go off to a meeting. I see there's some questions in the chat. Scleroderma requires normal skin biopsy for comparison. Always, I would say no if you know what you're looking for. It doesn't require a normal skin for comparison. If you see that loss of the spaces between the collagen bundles of the reticulodermis, I think that is diagnostic of scleroderma or morphia if you have the right clinical presentation. I think it is important to remember that sometimes the clinical findings are more advanced than the histologic findings. So sometimes you'll get a diagnosis of rule out morphia or scleroderma. You don't see the sclerosis, but you'll see a perivascular lymphoplasmacytic infiltrate in the dermis. And then when you see that, you can suggest the diagnosis of early morphia or scleroderma. All right, difficult to decide whether real bulla or artifactual separation of the epidermal layers. It can be. I would say friction blisters tend to be not inflammatory. So, like you see in epidermolysis bullosa acquisita, or sort of trauma. So they tend to be not inflammatory. So I would say that would be a clue to the diagnosis of a immunobolus type of blister as opposed to a traumatic separation or artifactual separation. Artifactual separation, if you're thinking about tissue processing, you look for sort of other sort of unusual tears in the tissue, etc., that don't look normal. All right.
Samina, any other question? Dr.
No,
Samina, have you got your both questions?
Thank you very much.
Okay,
I got my
Professor Zaida Rani, Dr. Zunaira Arshad, any question? Dr. Zunaira?
No, sir, I don't have any question, but I would say
any of your experience? Any of your
I'm
experience
saying
difficulty?
I'm saying that his comments are quite pertinent. It's just because there is sometimes the clinical picture is far more suggestive than histological picture, particularly in case of metabolic diseases like nutritional dermatosis.
This was very important during metabolic.
But if you don't have the clinical history, it does have some characteristic histologic findings. But absolutely, clinical picture is critical.
It means whenever you are looking such questions, you also take the history of metabolic diseases and deficiency. You also get the investigation of these tests. Professor Shugufta, do you have any question? Professor Shugufta?
Sir, I would like to ask sir about the Darier's disease because
Hmm.
recently we have received a case of Darier's disease and it was really very difficult for us to diagnose. So, what about your experience? What are the most important features which we should consider?
Well, I think you see that acantholysis, and I think the clinical presentation of the distribution of the lesions is very important. And then it tends to be more intertriginous areas, but I think that acantholysis in the clinical picture is very important with Darier's disease.
Okay, sir. Thank you so much.
So,
There was actually more proliferation and involvement of the follicular area.
That can
which
happen.
Yeah.
That can also happen in pemphigus and pemphigus vegitans, where you get
Yeah,
extensive
that's why it
involvement
was
of-
very difficult for us to differentiate.
Did you do direct
Dr.
immunofluorescence, or did you have access to that?
Dr. Steven, I would
No,
like to
sir,
ask
we
another
don't have.
question. Would you
Yes.
please explain coron in case of Darier?
Uh,
I'm sorry, what?
What we call acantholytic cells, corps and ronds, basically pronounced as
Sure.
coron.
yes, 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 yes.
Okay, so let me go back to. All right, core ronds and core grains. You have these abnormal dyskeratotic keratinocytes that are round. That's what we mean by core ronds. And the
Yes.
core grains, we get these abnormal dyskeratotic keratinocytes that look sort of like plump rice grains, like here up in the granular layer. So this would be the core rond, or the weird round keratinocytes. And these are the unusual sort of flattened or rice grain-like keratinocytes.
Thank you so much for clearing it.
Yeah. I apologize. I have to go to a meeting. We have our staff meeting today that I have to go to, and but I thank you very much for your attention. I look forward to meeting you all in Pakistan.
Thank you so much, Professor Steven, but we will request one more lecture on the malignant diseases.
That might take a little while. I'm not going to be able to do
you are,
that.
before coming to Pakistan,
I can try to put
think
something together before I come to Pakistan for that.
Thank you, sir. You will see we are getting everything from you on the online. Okay, thank you, sir.
All
Thank you
right,
so much.
we can try to do that online beforehand, but it might take me a bit to put that one together. Okay.
Okay, okay, sir, okay.
I will
Very good.
communicate with you about that. All right. Thank you for
Okay,
your
thank you
attention.
so much. Thank you so much. Thank you so
All
much.
right, bye.
Nice to see. Allah Hafiz. Allah Hafiz.
feels clean. I'm just trying to make it better. So you feel clean. No, there was one over here in Denver screaming this morning. Just haven't we? I was just sitting there. I felt something on my leg. I looked. There was a cockroach in my all the way up. And that's what I went there. I went like this. I went like this. Yeah. Bird. I couldn't have that one. We definitely need a lot of work. But I, you know, like, no, like she nerves. Yeah, yeah, yeah. I was I'm really not exactly. Oh no, they're big. They're huge. All I have for me. What can we? Nothing. Oh. We didn't know where it went. It is. You can find, okay, if, let's see if any of them will track it. Okay. Yeah, right to my dad. Yeah, the rest too. I hope that. It went under my desk and then find it after it left and like one for came. Really like the but then it went to Marshall. Then it went to Marshall. But I mean this was early morning. So take it out. And 2 weeks ago, there was one coming off the conference room. So AJ killed it because I stepped on it because I was talking to AJ and I turned around to go to my desk. And I stepped on it and I went, oh, that's so he killed it because that's what we were trying to like catch it, but we couldn't find anything. And I said that to her, so if it goes to my city, I didn't know it actually would. So, if I just see him, I'm like, okay, let's call somebody, like, we'll trap it or whatever, but like, we talk about the stuff on it, how should we do that? Yeah, we're all like, freaking. Oh my gosh, it's a great overvalue. We yeah. So just like we did all weekend. Or MRI, whatever. You can just look at it by like. Thank you, Frida. Sorry, I was just trying to find it. Okay, anytime, just yell, whatever you need. Yes. Thank you. After it's like the patients bring all our. Yeah. I will. Okay. I'll get a display. I'll get over all around here. Okay, thank you. Is that okay? Yeah, of course that's okay. Are you okay? I'm fine. I'm over it. Friend, class, hair. Oh, buddy. Buddy, that's not nice. Yes, tell her we're avenged her.